So I don't have any financial disclosures. I'm going to run through a bunch of different cases that I've seen in my practice, some of them straightforward, some of them not. Hopefully you guys will find this interesting. So when I see a new corneal ulcer patient, these are some basic things that I go through and think about. I ask them about contact lens wear and their hygiene with them. You know, do they wear daily contact lenses for a month at a time? Have they had previous episodes of eye redness, which makes me think about herpes? History of cold sores or shingles on their face. Are they using any eye drops like steroids? Have they had any trauma to their eye or recent eye surgery? And then on exam, I check corneal sensation on every new ulcer patient. My techs know not to give any drops. They check pressure with eye care. Is there some feedback? Does it sound okay?
It sounds great.
Oh, good. Okay.
Speak up a little bit more and I can turn the mic down.
Got it. And then I'm always thinking when I look at someone, is there anything unusual or atypical about this patient? And then is the cornea thin? You know, how close are they to perforating? How close should I follow this patient? And then when do I culture patients? I typically culture patients with corneal ulcers if they're central, if they're larger than 1 millimeter or 2, if anything about the ulcer is atypical, or if they've been referred for a non-resolving ulcer. I'll culture for bacteria or fungus. When appropriate, acanthamoeba, either a culture or a PCR. And then I rarely obtain viral cultures. I usually base that diagnosis on the clinical exam, but that's an option also. So the first case, this is a 72-year-old female. She had pain and decreased vision in her right eye for about a week. She'd had uncomplicated cataract surgery a month prior at an institution outside of OSU. She hadn't had any improvement in her exam over the past week after being treated, or the past day, I guess, after being treated with moxifloxacin by the referring doctor. And she had been on prednisolone up until the last week also. She was hand motions in this eye, and her pressure was 7. This is what she looked like. So her eye was a little bit red. She had a very distinct round infiltrate, sort of paracentral, with an overlying epidefect and sort of an epithelial plaque. She had a hypopyon, her cornea was edematous. There was no posterior view, but she did have some vitritis on her B scan. And so I did obtain bacterial and fungal cultures on this patient. Because of her vitritis, she saw one of my retina colleagues and got an AC tap and intravitreal vancomycin and ceftazidime that day. I started her on fortified vancomycin and tobramycin every hour and also cyclogel. I tell all my patients to try and separate their drops by a few minutes. And I know you guys all know this, but fortified just means sort of like a higher concentration of antibiotic than is available commercially. So her corneal cultures never grew anything, but her anterior chamber tap grew strep pneumo, susceptible to vancomycin and levaquin. She gradually improved over the course of about 3 weeks, and I stopped the fortified antibiotics, which I switched her to Moxi. I treated her with a month of prednisolone to try and shrink her residual scar. She ended up 2200 and pinholed a little bit better, but had good vision in her other eye and declined any sort of contact lens evaluation or a corneal transplant. I chose this case because typically hypopyons in the setting of corneal ulcers are reactive, not infectious. I would say in my experience, probably more than 95% of corneal ulcer patients that have a hypopyon, that hypopyon is not an infection. But in her case, especially with her recent cataract surgery, with her vitritis, we treated her like she had an endophthalmitis also. All right, the second case, this is a 55-year-old patient who had 2 days of eye pain in the right eye, denied any previous episodes of redness or pain, was not taking any current medications. Vision in this eye was 20/40, normal pressure. And this patient had sort of a classic herpetic epithelial keratitis, a dendrite with those terminal bulbs, stained nicely with fluorescein. The eye was a little bit red, but otherwise the corneal exam was normal. There was no AC reaction. So this patient has a herpetic epithelial keratitis, a first episode based on the history the patient gave. Anytime I see a patient where I'm probably going to start an antiviral, I always ask if their kidneys work okay, because valacyclovir and acyclovir are both cleared renally. And so if they have severe kidney dysfunction, the medications have to be renally dosed, or you could think about topicals instead. I started this patient on a gram of Valtrex 3 times a day and then ofloxacin 3 times a day also. The ofloxacin was to prevent any superinfection. And Valtrex is a very safe medication, and I'm referred a pretty large number of patients who have recalcitrant herpetic keratitis, and so I I would say typically default to a gram 3 times a day, even for a sort of a straightforward herpes epithelial keratitis like this patient, but 500 milligrams would also be very reasonable, of course. The important point for this case is you do not treat these patients with topical steroids because there are some strains of HSV that cause an epithelial keratitis that gets worse with topical steroids. So no topical steroids for this patient. By day 10, the dendrite had resolved. There was some residual scarring, but the patient was seeing well. We stopped their medications. I usually talk about long-term prophylaxis, but for a first episode with really minimal or no corneal scarring, I don't think that's necessary. So just a brief review of herpetic keratitis. It's caused by either HSV or VZV. They're both DNA viruses, and patients are exposed to these viruses initially, and the virus never leaves the body. It goes latent in the trigeminal ganglia, and it can reactivate as either a keratitis or a uveitis. Usually it's unilateral. I would say the exceptions are children are more likely to have bilateral disease, or patients with history of atopy. And it's important to distinguish between epithelial disease, which is usually caused by reactivation of live virus, versus a sort of a deeper presentation with a stromal keratitis or an endotheliitis, a disciform keratitis, which is more often immune-mediated in etiology. And then how do we make this diagnosis based on history? Do they get cold sores? Have they had shingles? Have they had previous episodes? On exam, you can look for skin or eyelid lesions, like vesicular eyelid lesions. You can look for a follicular reaction. Dendrites, like we saw in this patient. Anytime you see a keratouveitis, you should be thinking herpes, and then elevated eye pressure also. Decreased corneal sensation makes me think of herpes also. Zoster is the most common cause of neurotrophic keratopathy, so if their corneal sensation is decreased, think about zoster as a component of their presentation, and then you can check a PCR also. All right, next case. This is a 32-year-old male, eye pain and blurry vision in the right eye. He says this similar thing has happened 4 to 5 times previously, so you should already be thinking herpes when you hear that history. He doesn't get cold sores. His vision's 2200 in this eye. His pressure is the high end of normal, and this is what he looked like. So his conjunctiva is pretty injected. He's got a geographic epithelial defect with maybe some superimposed infiltrates along the edge of that epithelial defect. He had some corneal edema, and then you can't tell from this picture, but he also had 3 to 4 plus AC cell. So this is a herpetic keratouveitis with maybe a superinfection with those little white infiltrates. So I did culture him for bacteria and fungus. That didn't grow anything. I started him on Valtrex, moxifloxacin every 2 hours, and cyclogel, and I did watch him closely because of that possible superinfection. So I saw him back just a few days later, and he was already doing better. His epithelial defect was smaller. Those infiltrates looked a little bit more like scarring, but he still had a dense AC reaction, so I felt comfortable at that point starting him on prednisolone. A couple days later, he continued to improve. By 2 weeks after his initial presentation, his eye was quiet, but he did have residual corneal scarring. Vision was 20/40, and this is someone who definitely needs long-term oral prophylaxis. So I already talked about this, but it's important to think about the different ways herpes can affect the eye and sort of the mechanism of the presentation, either live virus or an immune reaction, because an immune reaction, like this patient probably also had, requires treatment with steroids. But again, in this patient, I was cautious with starting steroids due to that concern for maybe some sort of superimposed bacterial infection. All right, the next case, 45-year-old with a non-healing corneal ulcer in the left eye. This has been going on for 3 weeks. She wears soft contact lenses and often sleeps in them. She does have atopic dermatitis. She's been on Dupixent for the last 1.5 years, and that helped her symptoms a lot. She came to me on moxifloxacin and prednisolone, both 3 times a day, and she had recently been treated with Valtrex, and instead of improving, she'd continued to worsen. She was 20/40 in this eye. Her pressure is normal, and this is what she looked like. She's got some lid margin inflammation, maybe from her atopic dermatitis or related to the Dupixent. I don't think that was part of this case, though. Her conjunctiva is a little injected, and then she's got this unusual looking superior lesion, maybe sort of dendritic looking, or maybe you could picture that those are some branching hyphae in her cornea. There was an epithelial defect over this area too. The cornea was not thin, there was no AC reaction, her corneal sensation was normal. So this was a very atypical looking ulcer, I thought, when I saw her. And you might think herpes when you first see this, but she'd been treated with Valtrex, and she was getting worse, not better. So I cultured her for bacteria, fungus, and acanthamoeba, but I was very suspicious for fungus in this patient. She's a contact lens wearer with something that sort of looked like herpes, but was getting worse on Valtrex. So I started her back on Valtrex, increased the moxifloxacin to every 2 hours, and then I did start topical amphotericin for her as well, and I stopped her prednisolone, which can worsen a number of different corneal infections. So her fungal culture was positive for a filamentous fungus called Bacillomyces, which is a pretty rare fungus. I continued her on the fortified amphotericin and dropped her moxifloxacin down, and she slowly improved. By 2 months after her initial presentation, I was pretty confident her infection was gone, so I stopped her amphotericin. But I usually don't start steroids right away in fungal ulcers just because they can be tricky. I usually like to watch patients off antifungal drops for a while before starting a steroid. I've been fooled before. So I waited a month, and her eyes stayed quiet. So then we added prednisolone for a month to try and shrink that residual scarring she had. And she ended up seeing 20/20 with a scleral lens. Brief review of fungal keratitis. In my practice, I would say the most common risk factor is contact lens wear, but also think about it with like trauma or a history of someone gardening and their symptoms started while they were gardening or mowing the lawn. Clinically, these ulcers can have like a dry appearance, sort of the opposite of like a soupy Pseudomonas ulcer. They're sort of dry looking. You can see multifocal or satellite lesions, especially with Candida. They can have feathery margins. They can have a deep infiltrate with no epithelial defect. So if you see that, think about fungus also. They can have sort of like visible branching hyphae. I've seen that twice. This patient was one of those. And then, like I mentioned, steroids can worsen fungal keratitis. They increase the virulence of some fungi. So just be very careful with steroids if there's any possibility of fungus. The infections can also be very difficult to treat. So I set patient expectations once we have this diagnosis that, it could take many, many months to treat this problem. All right, next patient's a pediatric patient. He was 5, and he had 4 months of eye redness and swelling in both eyes, but his left eye had recently become very sensitive to light. He was referred to me by one of our pediatric ophthalmologists and was already taking prednisolone and erythromycin. He was also on Zyrtec. He had asthma and some seasonal allergies. His vision in this left eye was 21/50, but he did pinhole better. And these photos are actually from his examination under anesthesia that I did a month after his initial presentation, but this is pretty close to what he looked like when he first came to me. His eye was not very red, but he had this sort of like epithelial plaque in his superior cornea involving his visual axis. There's sort of like an epithelial halo, an epidefect overlying this area. There was no thinning. It didn't look like an infiltrate. And then if you flipped his lid, he had a few giant papillae near his lid margin. So this was a 5-year-old with vernal keratoconjunctivitis, VKC, and a shield ulcer. I didn't culture it because it didn't look infectious to me. But when I first saw him, I switched his prednisolone to Maxitrol ointment. I feel like ointment is better for kids. They tend to cry a lot, and the ointment sort of hangs around a little bit better. And then, again, in the setting of this epithelial defect, just to be cautious, I increased his moxifloxacin for that first week. And then he came back a week later and was totally unchanged. So this 5-year-old let me put a bandage contact lens in his eye, which I was very impressed with. It took a little effort, and I continued him on the Maxitrol and the Moxi. And I saw him every week for about a month, and at first his epithelial defect shrunk a little bit from about 3.5 millimeters to 3 millimeters, then maybe 2.5, and then it just plateaued and it stopped getting any better. Every time I changed his contact lens, his mom would take him to get ice cream afterward, which was very motivating for him. But anyways, a month after this bandage contact lens wear, he still had this epithelial defect, and so we decided to do something more definitive for him. But a quick review of VKC. So this typically affects young boys, and then they grow out of it at some point, thankfully, which is great. And they can get these shield ulcers. So what happens is the giant papillae underneath the upper lid rub on the cornea, and they cause an epithelial defect. And then with time, this plaque deposits and builds up on the epithelium. It's made up of fibrin and mucus, and that plaque prevents reepithelialization in that area. BKC patients can also present with limbal thickening too. And so what I decided to do for this boy, I took him to the OR, got these nice pictures. I did a superficial keratectomy, trying to remove as much of this mucoid plaque as possible. I then sutured amniotic membrane over his cornea. It covered his entire cornea. I used vicryl sutures at each of the 4 corners on the conjunctiva. I put a contact lens on top of everything, and then I injected Kenalog at the base of each of his papillae too to try and get those to shrink. 3 weeks later, his epithelial defect was finally resolved. He did and does have a residual corneal scar, but with glasses and patching, he ended up seeing very well. He's 20/25. Next patient, 66-year-old female, corneal ulcer in the right eye. She says that her symptoms began after gardening, and she was referred in by another ophthalmologist in the community. She's got moderate pain, but overall she's feeling better. She had a hypopyon when she first presented, but this is now gone. She's had LASIK in both eyes and cataract surgery. She does get cold sores and takes 800 milligrams of prophylactic acyclovir daily for those. She was hand motions in this eye when she first presented. And this is what her eye looked like. So her eye's very red. She's got this sort of indistinct central infiltrate with a lot of corneal edema and haze. Her LASIK flap was already melting inferiorly. The picture of the epithelial defect, you can sort of see the edge of the flap melting. And then it wasn't a great view into her anterior chamber, but she didn't have a hypopyon at least. And this patient actually came to me already with this diagnosis. The referring ophthalmologist had cultured her. It was positive for Fusarium, a filamentous fungi, and she was started on natamycin. So she came into me already on this treatment regimen. She was doing drops every hour, including at nighttime, and she was going crazy because she'd been doing this for, I think, 2 weeks already. So we dropped her natamycin to every 2 hours at night so she could get a little bit more sleep. I increased her acyclovir to 5 times a day, again, just to treat any sort of herpetic component that could possibly be contributing with her decreased corneal sensation. And over the course of about 2 months, she slowly improved, but her cornea thinned. She had this really thin central area on her cornea at one point, so I added topical voriconazole. And I tried to start her on oral voriconazole, but she was on another medication that interacted with oral voriconazole, so we weren't able to do that. But by 3 months of treatment, the epithelial defect had resolved. She still had a persistent infiltrate. It took about 6 months, though, for her infiltrate to finally resolve. She had central corneal scarring. I carefully added steroids. And this is what she ended up looking like. Her anterior chamber was deep. When I had her look into far, right or left gaze, I could see these iris strands going to the back of that corneal scarring. So I think she had a small perforation that self-sealed at some point. She was still, I think, maybe count fingers at this point. I did a corneal transplant for her 2 months ago, and she's healing appropriately. Brief review of Fusarium keratitis. It's one of the more common fungal keratitis pathogens that we see. And a good take-home from the MUT study, MUT1, was that for culture-positive Fusarium ulcers, patients treated with natamycin ended up doing better typically than those treated with topical voriconazole, which is why she was started on natamycin to begin with. And I only added the voriconazole when she continued to worsen. Next case, 49-year-old male, redness in the right eye and sensitivity to light. It's been gradually getting worse for the past month. He says that he has a history of herpes in the eye, so that history is helpful. He comes in on moxifloxacin and timolol. He lives 2.5 hours away. He does have HIV. He follows with a local infectious disease specialist, and I don't have records, so I'm not sure what medications he's on, but he does say that his recent viral load was undetectable. He also has moderate kidney dysfunction. He's 2100 in this eye, and his IOP is 23. And this is what he looked like. He had, you can't really tell from this photo, but his injection was most pronounced sort of temporally near that infiltrate. He's got a pretty distinct looking infiltrate right near his limbus in this eye with both superficial and deep corneal neovascularization. There's an overlying epithelial defect, and his cornea was starting to thin in this area. It was hard to tell exactly how much, but he had at least moderate thinning. So in this 49-year-old patient, HIV positive, with a peripheral corneal ulcer, I obtained bacterial and fungal cultures. His corneal sensation was decreased when I checked. I started him on fortified vancomycin and tobramycin, and then also started him on Valtrex 3 times a day. And his cultures came back positive just a few days later for a filamentous fungus called peniophora, which I've only seen once before in this patient. And I immediately started him on natamycin and decreased his fortified antibiotics. His infectious disease doctor helps me manage oral voriconazole for him, which we started at 200 milligrams daily. You have to follow LFTs in these patients, typically when you start the medication and then every month too. A week later, he didn't really look any different. And 2 weeks later, I switched his fortified antibiotics to ofloxacin, looking for some antifungal impact from the BAK, and that preserved ofloxacin. And week 3, his epithelial defect was looking smaller, but what was looking worse was his sclera. It was looking sort of like more inflamed and thickened, so I was worried he might be developing a fungal scleritis. So I injected voriconazole underneath his conjunctiva, adjacent to this area. Just of note, subconjunctival voriconazole is extremely painful. I don't think it's my technique. I think it has to do with the pH of the medication. And so after having this experience a few times, I now do subconjulido before injecting voriconazole, because otherwise patients will hate you. So a week later, he still didn't look much better. I did another subconjunctival voriconazole injection, and then I think he was mad at me for how bad it hurt, and so he didn't come back the next week. But he did come back 2 weeks later, and thankfully he was looking a whole lot better at that point. His epithelial defect had resolved, his infiltrate looked better, his sclera and conj looked less thickened and boggy and injected. And so over the course of the next month or two, I slowly decreased his medications, and 3 months after he first presented, stopped everything and started prednisolone. And this is what he ended up looking like, which all things considered, I thought was a good outcome. He didn't perforate and he didn't get a fungal scleritis, so. The next case is an 87-year-old female who was referred to me for non-healing corneal epithelial defects in both eyes. This had been going on for 4 to 5 months, and she'd been treated by the referring ophthalmologist with a number of different things: ointment, doxycycline, Valtrex, Procaras, Tarsorphes, and nothing really seemed to help. She denied any nosebleeds or mouth sores. She had had cataract surgery earlier this year, and she was hand motions in both eyes. So this is what her right eye looked like. So first thing that drew my attention was that the conjunctiva was very thick and boggy. She also had some loss of her inferior fornix, some early subconjunctival fibrosis, so sort of that like whitish, light pink appearance of the inferior tarsal conj as early fibrosis. You can't tell from this picture, but she had an epithelial defect that was probably 80% of her cornea, not much thinning, but her cornea was hazy. And then her left eye had a similar appearance, wasn't quite as injected. That bottom left picture, maybe you can imagine there's like an early symblepharon forming with, again, that subconjunctival fibrosis, this sort of unusual looking superior papillomatous lesion extending under her cornea with some vascularity. Again, a very large epithelial defect and haze in this eye. So I was very suspicious for mucous membrane pemphigoid in this 87-year-old patient whose symptoms began after eye surgery. And I felt like her epithelial defects were probably from an inflammatory limbal stem cell deficiency. I did culture her inferior fornices just to make sure there was no bacterial component to this conjunctivitis. I started her on erythromycin and antibiotic drops. I did an inferior fornix biopsy on that right eye, the more inflamed eye. I started her on oral prednisone, 40 milligrams. She's this tiny little woman, so I didn't want to do a higher dose than that. And then I referred her to dermatology. At our institution, they're the ones who help us manage pemphigoid patients. So unfortunately, her biopsy was negative, which is sort of the conundrum with doing a biopsy in these patients, because if your biopsy is negative but you still think they have it, you're still going to treat them. So do you really need to do a biopsy anyway? I was pretty sure she had mucous membrane pemphigoid still. Dermatology started her on dapsone. We felt like at her age, that was maybe the safest of the immunosuppressant options. And she slowly improved. By week 8, her ocular surface inflammation was gone. Her epithelial defects were a lot smaller. I treated her with bandaged contact lenses and slowly decreased her prednisone as dermatology slowly increased her dapsone, as she was tolerating it well. By week 12, her epithelial defects were gone, but her epithelium is still very, very irregular. She's got sort of like diffuse PEE. Her epithelium looks very wavy, very irregular, so her vision's still not great. But on dapsone, 100 milligrams, and a very low dose of prednisone, which I'm still tapering her off of, she's doing much better. She's still count fingers, again, I think because of her corneal haze and irregular epithelium. But she says sometimes when she blinks with both eyes, she can see better than that, she thinks. I last saw her within the last 2 weeks, and this is what her right eye looks like now. Her cornea looks nice in this picture, but if you put fluorescein in, it does not look nice. But there's no frank epidefects. And the inflammation near sort of that inferior fornix shortening and near her symblepharon is now resolved. So that's the place to look for persistent inflammation in these patients. But she does have that very prominent fibrosis of her inferior tarsal conge, you can see in that top right picture. And she's got sort of the superficial neovascularization slowly marching onto her cornea from her limbal stem cell deficiency. But hopefully she'll keep her eyes, you know. So just as a quick review, thank you, sure. Thank you. Mucous membrane pemphigoid is an autoimmune disease where autoantibodies are deposited along the basement membrane zone in mucous membranes, and this typically affects older folks. So think about it in patients who are in their 60s and 70s. You can get it in younger patients, but it's not common, and it can lead to blindness. And the treatment is systemic immunosuppression. Topical medications are not enough for these patients. Okay, case number 9. A 69-year-old patient with a non-resolving corneal ulcer in the left eye. This has been going on for 4 months. He says his symptoms began as irritation, and an outside ophthalmologist has been treating him for disciform keratitis with Valtrex and prednisolone for 3 months. He stopped the prednisolone for a week, but then felt way worse, and so restarted it. He's also been treated with a tarsorphine serum tears. He's had cataract surgery. He wears a scleral lens in his left eye because he had Decimase tears from a forceps injury when he was young. He does say that he cleans his scleral lenses with tap water, so you know where this is going. He is on Valtrex twice a day, ofloxacin and prednisolone. He's hand motions in this eye. And so this is what he looked like. His conjunctiva was very red. And first thing you should be thinking when you look at him is that he's got a pretty distinct ring infiltrate in the center of his cornea, unfortunately, with an overlying epithelial defect. But his cornea wasn't thin. But I saw this and I was pretty sure he had acanthamoeba keratitis. I did culture him for bacteria, fungus, and acanthamoeba. His corneal sensation was normal. But again, I'm always thinking that there could be a herpetic component to these patients. And so I increased the Valtrex to 3 times a day. I started him on chlorhexidine right away, topical chlorhexidine every 1 hour. It's a pool cleaner that acanthamoeba does not like. I also started moxifloxacin as well, and I stopped his prednisolone. And I told him, you are going to initially feel way worse, but don't worry about it, it's okay. So his corneal cultures, unfortunately, came back for both acanthamoeba and candida. And so we had a very frank discussion. This is going to be hard to treat. You're going to be on drops for 6 months, a year, just setting the expectations so he knew he was going to be seeing me for the long haul. I got to know him and his wife very well. I then also added topical voriconazole and oral voriconazole for 3 months for this patient. He wasn't really getting better a month into treatment, so I added PHMB. So he's now on chlorhexidine, topical voriconazole, PHMB, oral voriconazole. And then over the next few months, he sort of slowly improved, but just not as much as I would like. And then he stopped getting better around 4 months, so I had topical amphotericin. So this guy, poor guy, was on so many drops. And so 4 months after treatment, this is what he looked like. That ring infiltrate had sort of consolidated into this central infiltrate with sort of like some faint staining over it. And then this infiltrate just persisted. But it slowly got smaller and smaller and smaller until 14 months of treatment later, it finally resolved. But again, I was very careful to not stop his medications too quickly. So a month later, I stopped 2 of the drops, carefully added prednisolone, watched him closely. Another month later, I stopped the other drops. He was still on prednisolone. So this is like a 1.5 years after everything. And he's left with pretty significant central scarring and some faint corneal neovascularization, but no infection, which is wonderful. And I did a corneal transplant for him about 6 months ago, and he's 2100 right now without any correction. I'm taking sutures out. He's doing well. Quick review of acanthamoeba keratitis. So this parasite is ubiquitous. It's everywhere. It's in water and soil. And most cases of acanthamoeba keratitis are associated with contact lens wear. Pain out of proportion to exam findings. This is so true. These patients are miserable when they come in. And the trouble with acanthamoeba is that early on, it's very easily treatable, but the findings on exam are non-specific, and so it's hard to diagnose early. Later on, when it's easier to diagnose, because they come in with a huge ring infiltrate after like a month or two or longer of being treated for something else, it's easy to diagnose, but it's much harder to treat at that point. Treatment options for these patients. PHMB and chlorhexidine are the most effective. They're both cysticidal, so they kill that sort of really resilient cyst portion of the acanthamoeba. You can also treat these patients with Broline, which is not available in the United States. Tobramycin and neomycin are options, both topical and oral voriconazole. And then I've never used this medication, but supposedly you can use miltefosine also. And then thinking about, this patient used eye drops for over a year to treat this medication. So, why not think about maybe just doing early surgery for him, cure the infection, save him, some of the hassle of doing 5 hourly eye drops for a year. And I generally, if at all possible, avoid surgery in acanthamoeba keratitis for a couple reasons. So number one, you can't visually tell how far the parasite, those amoeba, those cysts extend, and so you really need to do a large graft. And you still can't be sure that you got them all. Number two, I don't really like the idea of providing access inside of the eye for amoeba. There was a case series published in the Cornea Journal 2 years ago out of India. 4 cases, routine cataract surgery in India at 2 nearby surgery centers that all got acanthamoeba endophthalmitis. 3 ended up light perception and 1 ended up enucleated. And so I just feel like keeping this thing out of the eye is way better. And then in general, inflamed eyes just do less well with corneal transplants. And so even if you do a transplant for these patients early on, there's a high likelihood that graft is going to fail. You really can't treat them with topical steroids post-op, and so you'll need to do more surgery in the future. So that's my general reason for preferring medication initially over surgery for these patients. All right, next case, 21-year-old male. 3 weeks of foreign body sensation and pain in the right eye, and he says this pain is severe. He feels horrible. He's miserable. He says it's 9 out of 10. He's been treated with acyclovir, a decent dose, and he's not getting any better. He does wear soft contact lenses, so I'm always suspicious of soft contact or contact lens wearers in general. He sleeps in his lenses. He doesn't wash them with tap water, no pools or hot tubs. He's 20/60 in this eye. And this is what he looks like, which is a really pretty non-impressive exam. I have another photo on the next slide, but his eye is a little bit red. He's got sort of these whitish, just barely elevated, sort of central or paracentral epithelial-looking lesions. On sort of this like sclerotic scatter picture, you can see them backlit a little bit. Again, they're sort of non-specific. Maybe you look at this and think herpes. They stain a little bit. His epithelium's a little irregular. But again, he's been treated with antivirals, and he is miserable. He says this is the worst pain he's ever had in his entire life. And so I was worried about early acanthamoeba. Again, it's very non-specific early on, starts in the epithelium, and then penetrates deeper into the eye and becomes harder to treat. So I cultured him for bacteria, fungus, and acanthamoeba. His corneal sensation was normal. I started him on Valtrex and moxifloxacin, waited for these cultures to come back, and 3 days later, his acanthamoeba was actually a PCR, and it came back positive. So I treated him with chlorhexidine every hour for 2 weeks, and he came back and looked completely normal, felt back to normal, and then didn't come in for any more follow-up. So I think he's doing okay. But this is the earliest case of acanthamoeba keratitis I've personally seen. Next patient's 22, referred for a corneal infiltrate in the left eye. The optometrist was, wondering what this spot was. She said she had 4 days of pain and foreign body sensation. She's also a contact lens wearer. She doesn't sleep in them, but she wears them for a long time. She doesn't clean them with tap water. Her vision's 20/20 with her glasses. And this is what she looks like. It's probably hard to see from the pictures, but right at her superior pupillary margin, I'm going to show you, and then unshow you. There's this sort of like perfect geometric circle. And this is a Wesley immune ring. So this is not an infection. It can be a response to an infection, or it can develop just in contact lens wearers. But this geometrically perfect circle. So I didn't culture her. There was no epithelial staining. I didn't think this was an infection. But again, these can be caused by contact lenses. And because she's a contact lens wearer, I'm always thinking, could there be an infectious component, even though I didn't think there was? So I told her to stay out of contact lenses, try Moxie for a week. There was no change in her exam or how she felt. I treated her with steroids for a week. She felt way better, symptoms gone, but her corneal exam still looked the exact same. And then I haven't seen her since either. So what is a Wesley immune ring? So these are sterile intrastromal reactions to foreign antigens. They can be infectious, like I mentioned, or contact lens wear. I think there's a number of other things that can cause these too, but they're geometrically perfect. That's how you distinguish these from something like a ring infiltrate from acanthamoeba. And they're usually peripheral near the limbus, and they usually don't affect the vision. Next case, 75-year-old female, blurry vision in both eyes. This is a really unfortunate case, actually. She had been admitted to the hospital 2 weeks prior for arm surgery, and she was sent home from the hospital with a bottle of chlorhexidine to clean her arm skin, and she thought it was her contact lens solution. And this is not the chlorhexidine strength we use to treat acanthamoeba. This is full-strength chlorhexidine, which I think is 4%. She used it to put her contact lenses in her eyes. Her eyes burned like crazy. She waited about a minute and then took them out, and then her vision's been blurry ever since. She's count fingers in her right eye, 2,400 in the left eye, and she's currently, when she first came to me, she was just using artificial tears. So this is the bottle she was sent home with. So I guess if you don't have your contacts in, you're not wearing glasses, it's easy to see how you could maybe mistake this for your contact lens solution bottle. She had no frank epithelial defects when she first came in to see me, but just very diffusely irregular epithelium and corneal edema in both eyes. She also had cataracts in both eyes. Her eyes were a little inflamed too, but her fornices were nice and deep and looked normal. So unfortunately, this was a patient with a severe chemical injury to both eyes. I immediately started her on frequent topical steroids and moxifloxacin, again, just for infection prophylaxis. And then to try and help promote corneal healing, I also started her on oral doxycycline. The highest dose I'll typically do for that is 100 milligrams twice a day. And then for the same reason, corneal healing, to try and promote it, vitamin C, I usually do a gram BID, but I think you can dose that even higher. And then over the course of the next weeks and months, she had these sort of waxing and waning epithelial defects in both eyes as her ocular surface inflammation slowly resolved. Her epithelial defects, I think, were mostly from a limbal stem cell deficiency, but probably her corneal edema was playing a role too. I treated her with bandaged contact lenses and changed them monthly. By 3 months after her initial injury, her right eye had improved to 2150, but she still had persistent corneal edema. Epithelium was very irregular. Again, she had that cataract. Her left eye was not seeing as well. She had sort of more haze in that left eye with an epithelial defect that even with a bandaged contact lens, I couldn't get to resolve. And she didn't see any better with the refraction in either eye. So I decided to do a phaco-DSEC on her right eye 4 months after her initial injury, and she ended up doing very well in her right eye. She's seeing 20/60, pinhole's a little bit better. Her vision does fluctuate a little in this eye, again, I think from her epithelium not being totally normal, but her graft is clear, and this is what her eye looked like, I think, about 6 months after her initial injury. Her DSEC graft is decentered just a little bit superiorly, but is nice and clear. And then you can see in that fluorescein photo on the right that her epithelium centrally looks pretty normal, but peripherally still looks very abnormal, again, from some degree of limbal stem cell deficiency. Now her left eye we turned attention to once the right eye was doing well, and her left eye corneal edema had actually resolved, but she still had a lot of haze, these sort of persistent epithelial defects, irregular epi, and a decent cataract in that eye, so we decided to try cataract surgery. One tip I have for you guys for cataract surgery and abnormal corneas is to turn off the diffuse lighting, because you get less glare from the corneal haze and scar, and just use the red reflex lighting. That makes these cases feel a lot safer. And unfortunately, cataract surgery in the left eye didn't really help her vision, mostly because of her cornea, I think. She had these persistent epithelial defects. We discussed the possibility of a limbal stem cell transplant, but we couldn't take tissue from her other eye because her other eye has abnormal limbal stem cells too, and she didn't have any family members who could donate, so her only option would be a cadaveric graft, and you have to be immunosuppressed for that surgery, which she didn't really want to do. So we had her try a scleral lens, and she sees a whole lot better with a scleral lens in that left eye. She gets to 20/30. She has some trouble with application, so she doesn't wear it that often, but this is what her left eye looks like. In the color photo on the right, you can see the scleral lens in her eye, sitting nicely on her sclera, vaulting over her cornea. And then in the fluorescein photo, that's a later photo, you can just see just really irregular, abnormal corneal epithelium. All right, one more pediatric patient. I think this is the last pediatric patient. This is a 7-year-old this time. 3 months of eye redness in the left eye, worsening photophobia in both eyes. He does have autism spectrum disorder. He was 20/30 in both eyes, and this patient was referred to me by one of our pediatric ophthalmologists who had a really hard time examining this patient in clinic because he was so sensitive to light. And so the first time I met this patient and his family was for an exam under anesthesia in the OR. The referring pediatric ophthalmologist was actually suspicious for cystinosis. And at first glance in this picture, maybe you'll realize why. The cornea in this right eye looked pretty normal. There was some mild PEE, but otherwise the cornea looked pretty normal. The conjunctiva looks very abnormal, though. It kind of looks like sandpaper or like reptile skin, just very dry and sort of leathery looking. And then the left eye was the worst eye. The cornea does not look normal in this eye. Diffuse PEE, very dry, very xerotic. There was a sterile ulcer in this cornea with just mild thinning, but no infiltrate. There was an epithelial defect. And the conjunctiva in this eye is a little more inflamed, but again has that sort of thickened, leathery appearance. So we heard a little bit about vitamin A deficiency yesterday, and this is sort of what even worse vitamin A deficiency can look like. So this exam is diagnostic of vitamin A deficiency, regardless of labs. If you see conjunctiva that looks like this is vitamin A deficiency. So once I saw this patient, I talked to the mom a little bit more to get some history, and for the last 4 years, he'd only eaten French fries and chips. In spite of trying feeding therapy with an occupational therapist, they had just not been able to get this sweet boy to eat any more than French fries or chips. And so he did end up having a low vitamin A level. It takes a week for that lab to come back, though at our institution at least, it's a send out. He also had low vitamin D. He had an iron deficiency anemia. He was admitted to the hospital, and he eventually got a G-tube, actually. I cultured that corneal ulcer in the left eye, even though I thought it was sterile, just to be sure. Started him on moxifloxacin and ointment, and then we had him admitted to the pediatric service at our children's hospital, but they were very reluctant to treat him with very high-dose vitamin A without a confirmatory low vitamin A lab, and like I said, it took a week for that lab to come back. And so rather than treating him with an extremely high-dose vitamin A, which can be toxic in patients with normal vitamin A levels, we sort of met in the middle and treated him with sort of like a moderate daily vitamin A supplementation. He got a multivitamin with high-dose vitamin A, and then a vitamin A tablet, I think it was sublingual, that was 10,000 international units per day for 30 days. And within a week, he was already feeling better. These patients can get better very quickly with vitamin A supplementation. 2 weeks later, his epithelial defect had resolved in the left eye. His conjunctiva was looking a lot more normal. And by month 2, he had a little bit of a corneal scar in that left eye, but otherwise, his eye exam was back to completely normal with pretty good vision. So again, like we talked about a little bit yesterday, vitamin A deficiency is necessary, or vitamin A is necessary for both rod function and maintaining normal mucosal cells throughout the body, including the conjunctiva. Early on, it can present with night blindness, but it can progress to these sort of severe findings. These patients, those ulcerations can progress to perforation too. And it's really important to know about this diagnosis that if it's untreated and they have eye symptoms like this, the mortality rate within 1 year is 50%. And so this is really to some degree an emergency to treat these patients with vitamin A repletion. And then, like I said, the WHO recommends these very high doses. We couldn't get our pediatric hospitalist to agree right away to doing that, but this patient still did fine. All right, next case. I think I have 3 more left. This is a 67-year-old, pain and drainage in his left eye. He'd been following with a corneal specialist outside of my institution because of a recent sterile melt in this eye. He'd been glued, he had a bandaged contact lens, and then Saturday morning, he called that cornea specialist and said, hey, I had a gush of fluid, and she said, go to the ED at OSU, they'll take care of you. So that's how I became involved with taking care of this patient. He does have a history of seronegative rheumatoid arthritis, which has been very difficult to treat for 30, 40 years. He's failed a lot of different medications. He's got chronic hand and foot deformities. He's had uveitis in both eyes. He's aphakic in both eyes. He's had glaucoma with tube shunts in both eyes. And he had a prior melt in this eye 2 years ago that was successfully treated. He's currently on oral doxycycline, an unknown antibiotic drop, Humira, and 10 milligrams of prednisone, which he takes per day chronically. He was light perception in this eye, not very good vision in his other eye. And this is what he looked like. So his eye is very red. His cornea had sort of diffuse haze with sort of a pretty large looking infiltrate. And then that orange-red circle in the middle of his cornea is a 4-millimeter perforation. Remember, this patient is aphakic. And the reason his eye is not collapsed is because that bandaged contact lens was still in his eye, sort of like holding its shape. So this patient underwent perforation was too big to glue. I love gluing corneal perforations whenever possible, but this one was way too big to glue, obviously. And so I did an emergent PK for him, a patch graft, and this is what he looked like near the end of surgery. That silver ring is called a Floringa ring. Anytime there's a chance of the eye collapsing, remember this patient's aphakic, I sew that on and then fix it to the drapes to sort of keep everything suspended during surgery. I also glued an amniotic membrane on top of this to try and help with healing. So he had a perforated rheumatoid melt, which looked like it was maybe super infected, which is a very challenging combination to treat. We sent his corneal button for cultures, and it grew Pseudomonas, susceptible to a number of different medications. He was admitted to our hospital, treated with IV Levaquin, also IV steroids, and then switched to oral steroids after 3 days. We started him immediately on fortified antibiotics, and once that culture came back, we switched him to cefazolin and moxifloxacin, which both have activity against Pseudomonas. I think it was ceftazidime and moxifloxacin. He's on doxycycline and vitamin C. Rheumatology saw him and started rituximab for us. I really like rituximab for patients with recalcitrant rheumatoid arthritis-related corneal melts. I think it's a really good medication for those patients. He developed hemorrhagic choroidal effusions, a new hypopyon. He got a tap and inject. He's slowly epithelialized, but unfortunately he ended up Tysical. But he's light perception. He kept his eye. He's back down to his initial medications. He didn't want to take any sort of escalated medications, even though we talked to him about the risk of this happening in his other eye. But quick review of rheumatoid arthritis and corneal melts. Typically, RA causes 2 kinds of corneal melts. You can get the paracentral melts like this last patient had, or you can get the more classic peripheral ulcerative keratitis. This patient has a photo of mine who had bilateral PUK and psoriasis, which was very difficult to treat. And corneal melting in these patients indicates that their RA is not adequately controlled systemically. So the treatment is temporary oral prednisone until you can escalate their systemic immunosuppression. Okay, 2 more cases, and I have videos for both of these. I'm not sure if I have time to show the videos, but so this is a 52-year-old male, another non-resolving corneal ulcer, 2 months of pain and blurry vision. He'd been treated with a number of different medication options, including 2 rounds of fortified antibiotics. He was currently on Valtrex and vancomycin and tobramycin. He wore scleral lenses for keratoconus. He's hand motions in this eye. And this is what he looked like initially. His eye is very red. Maybe you can hallucinate that you see sort of like the suggestion of a ring infiltrate here. I thought I did when I first saw him. He had an epithelial defect, but I was very suspicious for acanthamoeba in this contact lens where corneal ulcer not resolving. I cultured him, increased his Valtrex like I typically do. And then his wife was a pharmacist, so she had a lot of questions about sort of the different treatment options for him. So we did go ahead and start oral voriconazole for him right away too. You know, maybe it would treat sort of like a fungus, but it would also help with acanthamoeba. Started him on chlorhexidine every hour in that left eye, as well as atropine. And his cultures did return positive for acanthamoeba. After a month of monotherapy with chlorhexidine, he wasn't really improving, so I added PHMB. By month 2, he was slowly improving, but his pharmacist's wife wanted to try Broline, which is not available in the US, so they ordered it from Australia on eBay and then brought it in. We looked at it together. We thought the packaging looked, somewhat professional. So we talked about risks and benefits, and he did try it 4 times a day for a while, and he didn't get a whole lot worse, so that's good. But he slowly improved. His LFTs did go up. I was checking them monthly while he was on the voriconazole, so we did stop his oral voriconazole at one point. And it took 9 months or so of topical medications to treat him as well. We added steroid for about 2 months. He was left with a dense residual scar, posterior synechia, and a visually significant cataract. So we talked about the options. My preferred surgery strategy for patients like this is to do a corneal transplant, let them heal for a year, year and a half, and then go back and do the cataract surgery later. I just think it's safer that way. But he really wanted both done at once. So we did a PK triple. Let's see if the video plays. Oh, it is playing over there. Okay, not here. Okay, I'm going to step down. Can you guys still hear me? Okay. So he's got a Floringa ring on, again, just to support his eye. Starting the surgery like a normal phaco. I put a ring in, broke up his posterior synechia. I was hoping to do the rexus with his cornea on, just because it's much safer than an open sky rexus. Putting on more trypan. Again, I think I've got those diffuse lights turned off here. You can see I just have the red reflex lights to help with the rexus here. One of the scarier rexuses of my life. Hydrodissecting. And then I started to phaco, but at some point I just couldn't see. And so I didn't feel like it was safe to continue phacoing. So you'll see here that I suture the main wound and then plan to take his cornea off and take the cataract out open sky. So doing the partial thickness trepanation, you'll see that trepanation is decentered a little bit away from his main corneal incision. I was okay with that. It's decentered nasally too, and the visual axis is decentered slightly nasally, so I think that's fine. I'm cutting off the corneal button here. This is the part of the surgery where I say to the scrub tech, don't leave the room. Or the nurse, I'm sorry, the circulating nurse. The scrub tech can't leave. I also have the anesthesiologist give mannitol at this point to try and decrease any posterior pressure. He didn't have any, thankfully. And then at this point, I just hydrodissected sort of around that nucleus to pop it up. Remember, I'd already phacoed it, so it was already sort of in 2 halves, not fully split, and it wasn't a very dense lens, so it sort of just came out in pieces. It wasn't that satisfying, actually. And then at some point, his ring became dislodged and was sort of in the way, so I just took it out. And then he does have cortex still, so I'm doing open sky, IA, which you have to be careful of because you can't see really what you're doing. You just have to be super careful, keeping the IA really flat. And then I'm just checking for vitreous. I didn't think there was any, but everything looked good. So I put a lot of viscoelastic into the sulcus. I really don't worry trying to get a lens in the bag for these cases. I just put a 3-piece in the sulcus. And then the rest of it's a normal corneal transplant. Once you get those first couple sutures in, you're kind of like, woo. I don't think the rest of this is exciting. I could probably go to the next slide. Okay. All right, so he is 6 months out of that surgery. He's seeing 2200 and pinholes better. He's got a lot of cyl on his pentacam, so I'm selectively removing his sutures to try and minimize that cyl. Last case, I also have a video for this one, but I think it'll be quick. So this is a 35-year-old, progressively worsening blurry vision in the left eye, wears cosmetic lenses, sleeps in them, wears them for multiple days at a time. Has light perception in this eye, and this is what she looked like. You guys probably look at this if you're not cornea specialists and you're like, ooh, thank God I'm not a cornea specialist. So this is kind of gross looking. So like a lot of purulent discharge, the eye's very red. It's a limbus to limbus infiltrate, total epithelial defect. There was no view of the anterior chamber. This patient was started on fortified antibiotics every hour, and the cultures grew Pseudomonas, which explains sort of the rapid progression of this ulcer. This patient was on fortified antibiotics for 2 months. They were finally stopped, and I switched her to prednisolone. The bottom picture with those nice false eyelashes, this patient, 4 months after the initial presentation, was still light perception. There was no view of the anterior chamber, but I was suspicious that it was flat, even though this patient had been sidal negative. I think at some point probably perforated somewhere. There was a normal B scan, but not a normal UBM, and we also planned for surgery for this patient. This is what the UBM looked like, which is sort of daunting. So the iris is plastered up against the cornea pretty much everywhere. There's sort of like some fibrotic bands, maybe adherent from the iris cornea structure to the lens. So I was suspicious this patient probably had a dense cataract too in the setting of that severe inflammation for so long. So we talked about once the cornea came off, if there was a cataract and it was dense, we'd probably try and take that out too. So, all right, one more surgery. So marking the cornea here. This patient had pretty impressive pigmented epithelial hyperplasia too as she healed. So this is a partial thickness trephination. So very carefully removing the cornea, because again, the iris is right up next to it, but I sort of anticipated that there would be some degree of iris damage. But the cornea was just very adherent to everything underneath it. You can get the hint of that white cataract starting to show. Those are Van Ness scissors, again, just cutting those adhesions. Corneal button's finally off, and yes, there's a white cataract. This patient, instead of a Fleringa rings, our surgery center didn't have them that day. I put superior and inferior rectus stay sutures to hold the eye up. Put some trypan on, started potentially what was supposed to be a can opener capsulotomy, which quickly changed into that, but it didn't go all the way around, thankfully. And then the lens just delivered itself, which was helpful. The anesthesiologist I also was having give mannitol at this point to decrease any posterior pressure. And this patient had very little cortex. It was all liquefied, basically, so I didn't have to IA. I basically just jetted BSS up against the capsule, and also checked for vitreous with a Wexel. There was no vitreous. That posterior capsule was miraculously intact, thankfully. And then I put viscoelastic into the eye, trying to inflate the sulcus with a 3-piece IOL. And there was some good posterior pressure, not just intralenticular that caused that rexus to radialize, but I think also from the vitreous too. And so this optic just wanted to keep popping out. So I had my fellow with me, so we were holding the optic back. Then again, you get the first couple stitches in, and you're like, okay, everything's closed. It feels good. Usually once you get 4 stitches in, it feels better. Generally, it's 16 interrupted sutures for PKs, but this patient's peripheral cornea was very abnormal and thin in a couple areas, and so she needed some extras too. But ended up with a nice graft, sidal negative. And so she's now 2 months out of surgery, 2,400. Pinhole's a little bit better, graft edema is still clearing, but overall is doing fine. Quick review of Pseudomonas, soupy ulcers. They can progress rapidly, they can perforate, they can take a long time to heal, and that's all I got. Questions or comments?
I have two.
Sure.
The first one, do you have any objection when you're doing phaco on these corneas with residual scarring of using like Bausch & Lomb's new Apthera lens with a small aperture to try to reduce the glare?
I don't have any personal experience with it, but that's probably their only option, I would say, to get any sort of near vision, because you're not going to use any other lens beside a monofocal in them, right?
Right.
But I don't have any experience with it.
Okay. Second, generally this stuff for those of us non-cornea doctors, I'm thankful that I have a cornea partner now, and if one of those comes in, I just bang on the wall, and he takes care of it. But so that kind of stuff generally shows up on Friday, afternoon or something for us. But so my first day of practice 15 years ago, which was July 7th, 2008, I get my senior partner comes, bangs on the wall, says, "What is this?" And it's it was an acanthamoeba because they were swimming in the lake on the 4th of July.
Yeah.
It actually happened 2 years in a row on the first day after the 4th of July. But for those of us who aren't in tertiary centers where the labs have no idea how to culture acanthamoeba, I know how to do it. I asked for like a heat-killed E. coli tray, and they looked at me like I was asking for the keys to the space shuttle. And no pharmacy in the area could get any of this mess. Actually, the first time I went to like a pool store and diluted like polyhexamethyl biguanide myself and gave it to them. Like, what is the like Friday afternoon emergency recommend? Like, what do we do first? We're stuck. We can't do anything.
Maybe neomycin, something you can get over the counter. But I mean, waiting a few days is not going to be the end of the world. It's not like they're going to perforate. Acanthamoeba rarely perforates. So even though it's a tough to treat disease and you want to start treatment as soon as possible, it's not going to probably have a huge impact if the patient has to wait a few days to get appropriate medications. Yeah.
Oh, I have a comment to that. If you want, on the Friday afternoon, you can call O'Brien Pharmacy in Kansas City.
Oh, yeah.
They
ship
deliver
medications.
overnight. So O'Brien Pharmacy, they're very good.
They're a good pharmacy.
I just have two comments. Wonderful talk. On the cornea transplant with the triple, you can actually use Simcoe. You don't have to use the IA. Because
I have used the Simcoe. That would be a very reasonable option also,
That's
yes.
right.
Yeah.
The comment is the anti-acanthamoeba. I mean, now that with the new oral medication, I wouldn't wait 9 months. I mean, because the topical medication and then voriconazole, they're not specific for that. So in Pervido, we have been trying to do that at Hopkins, and it seems to be pretty good. But it does require prior authorization.
What is the medication?
In Pervido, I mean, you mentioned that.
The one that I haven't used before? Oh, okay.
Miltefosine?
Focine,
Yeah. And then the last comment is the antifungal. And now, if they're not responding, we're actually doing the 34-gauge needle intrastromal voriconazole.
Yep.
That seems
Good
to be
option.
pretty effective as well.
Agreed.
But wonderful talk. Thank you.